Filbrun, I think that we are not really following the model we have in the US. Especially, I think we don't have the exact same model you have in the US. They may be closer to the model they have in Michgan. It's definitely something that we can set as an example and follow some of the steps. Our hope is to have a CF center that will be suited to our system and, of course, serve our patients and help us also be able to provide this kind of service to a large number of patients or the available number of patients in the best way possible. Before moving on to the next speaker, there's one person. Thank you
very much, Samia, for informative lecture and for taking the time to come to Egypt with the long journey in the university. I have some few comments because we have started 20 years ago with a team that is going bigger. They didn't take any extra salary at any time, and the nurses as well. Regarding the point of the 400 CF patients, I think we have even more.
No, that qualifies for per capita.
Yes, this is very important.
No, we have about
our studies, genetic studies, have shown that delta F concentrated 508 is present in around 54% of our patients. So around half of our patients are not eligible for the treatment. And of these, we say half are homozygous and half are heterozygous, and we don't know the other gene whether it's eligible. And most of the other patients have their genes. So this is one point. Which patient is eligible? Most of them come from distant parts of Egypt. It's very difficult for them to come to Cairo to take the medication, and they have to sometimes spend 10 or 12 hours in the train. They are not in a condition that will give us the best result with treatment. Because in the USA, from the start of the diagnosis, they have topramycin, if there is pseudomonas, they have palmazine, they have carrion. I have my patients, several that are included in the project and are taking Trikafta. They come to me, they don't have any carrion supply, and supply them with them with the carrion, and all the other downstream treatment is not done properly. So to get the best of Trikafta, which is a very expensive medication, and it's very good that it is available in Egypt, and will help a lot of families, especially families with more than one siblings. We have them a lot in Egypt because of the high rate of hospitalization. And I have a family with who you know the woman. We have just lost the older child with severe pneumonia in an ICU and ventilated and so on. He was 26 years old. And both he and his brother have very rare disease, so they cannot be included. So this is another point what to expect right after from a patient who is not following the basics from the start.
Can I respond? Look, I come here. Here. All right. So it's really it's very important the number of patients in Egypt. So it's about 800 to 1,000. This is what we have now, and the projection is once we have the sweat testing available, still the gold standard, is that we should have 5,000, 6,000, something like in that range. So we're way away from getting everything, getting all the CF patients. So that's one thing. Second thing, there are countries in the donation program for Vertex that don't have enzymes, that don't have anything, and they are using just Trikafta. Tunis is one of them. And yeah, so Tunis has there are about 35 patients that qualify there. They don't have enzymes, they don't have anything other than albuterol, some antibiotics, and yet they are doing much better. So yes, you are supposed. I mean, Creon is available in Egypt, and now it is available, and we can get it. So I know, but it's getting better because the Ministry of Health is allowing Dr. Iman to be part of the committee that dispenses the medication, and she's been working on that. So it's been better. But we still should see benefits from Trikafta. The problem is, I don't know where the hesitation is of all the patients coming in to get it. They're all waiting to see what side effects other patients have. I'm sorry, this is a drug that's been in the market for 5 years. We already know what side effects it is. So you don't need to wait for others. You can just, so I think it's a matter of educating your family. It's like, it is a study, it's a drug that's been in the market for 5 years. And before the 5 years, it was another 5 years of research. So we know exactly what side effects it is. So get in and get the drug. So this is a golden opportunity. So that's another thing to keep in mind. Trikafta is approved for the Delta F5 but approved for 300 or 400 other mutations. So there are a lot more that we can get. And then also, and I'm not saying that too loudly, there are some patients that you can start as a compassionate use if they are sick enough and you wanted them to get the drug. It all goes through me, so that way I can have control over the process. So yes, but we can work on that. So having medication from Toby or not Toby, it doesn't really matter. It's what matters is let's give it to patients. They are giving us 400 for patients, 400 patients. Let's give it to the patient. So that's really very important.
100%. I think the problem here is the genetics. A lot of our patients are missing the genetic test, or it's like a certain mutation only, which is not really not possible for the mutation qualified for Trikafta. The problem is with the genetics. We try to do anti-genetics through the technique, but it takes a lot of time. Trained patients is very technique. يعني كل ده تأمين they will not pay. It's taking a month. And one patient is taking now another 6 months or 8 months and it's not doing it yet. I tried to talk to Iman, he's trying to help. But the point is beyond our capacity, related to the genetics or other conditions. A lot of patients are missing the test. They did it years before and they don't still work. They lost the result.
Oh, they don't.
They don't have the result. This is a problem.
Right, and actually, I'm meeting with Dr. Hassani tomorrow, and he is the assistant to the Minister of Health. He is in charge of the rare diseases, and he's working. There is a rare disease initiative from the president. He's working on that. That's why he was very, but he has to do this now and that. And that's why Trikafta came to Egypt. I mean, it was delivered to the customs and then we got it out in 2 months or less because of him. And this is not because of Aisha, probably the government is still there in the airport. So I'm meeting with him and I'm going to talk to him about issues. He's very, very receptive. I've been working with him the last 2 years, and every time I'm asking for something, at least something moves on. So right now is now part of the Ministry of Health. Especially because I asked for that. So I'm not trying to get credit, but this is what happened. So the focus this time I'm going to be the sweat testing because a lot of times we cannot even sweat the patient. And then the genetic. He said before last year, but that didn't happen yet. Oh, genetics will do it, no problem. We can do the full sequencing. I'm like, so I don't see that yet. So I'm going to talk to him about that. But yeah, sweat test and the genetics. But if there's anything else, any other issues, let me know because I can talk.
Patients have a rare mutation that are very rare. So I'm considering this one right. I know there is a note in the protocol to have to put patients with rare mutation. But is there a possibility for an exception if the parents agree and sign an ethical side effects and so on?
So there are
Because I have a lot of parents asking this question.
Right, there are two things. The first one, this is overqualified patients get the trifecta. I want all the patients that qualify, which is close to 400, get the trifecta. Then we can worry about the rehabilitation. But at this time, if there are any specific patients that you think would benefit from trifecta, let me know, and then I can work with the vertex with that. Yes, you can talk to me.
Dr. Nasser, can I say one thing as a
Yeah,
mom?
absolutely.
Okay.
Laura is actually, Egypt is her second country.
I love you all, my CF family. But I just want to say, as a mom, there's another way. Parents can WhatsApp me and ask me, they do, but I can tell you when my daughters, Molly and Emily, went on Trikafta, you can see the changes every day from the first day. If they're scared, I can tell them the drainage from their nose, that the inflammation goes away the first day. We had them journal and keep track of everything. It's so exciting. My daughter, Emily, who coughed for an hour every morning when she woke up, on day 4, stopped coughing. Like, it's dramatic and it's right away. So I just encourage them to listen to everything because it's unbelievable.
And it varies actually, so we have to be very accurate, very careful with that. Some patients actually keep coughing for 2-3 weeks after. It's okay, because they have more disease and it's bringing up all the secretions. Some of them start draining from their nose like a lot. One kid actually went to the emergency room because of that, but it was because he had a lot of his sinuses and now they're draining. So it depends, and we actually have a group, because I don't have the drug right now, with the pharmacist and our pharmacist, and I'm on it, of course, and they're all dispensing the junior faculty and the Dr. Teresa and Dr. Emmanuel on it to see if there's any side effects. We can let them know, relax, that's okay, or do this or do that. The funny thing is that now any disease they get, like one of them got the hand, foot, mouth disease, and they're blaming Trikafta. It's like, no. So my job is to tell them no. or the kid had something or the other is like, you can't get sick. I mean, it's not good. You're not going to be sick. So, but yeah, so we just need to encourage as many as we can to get the Trikafta, because otherwise we're going to be wasting the drugs and Vertex is going to come back again. But what numbers did you give me? So I want to make sure that that's done correctly. Right.
Thank you, Dr. Samia. Tafadhali, Dr. Samia. I'd like to thank before everything Dr. Rasha Gamal, مدير المستشفى الياباني. يعني it would not be possible to have this if it were not for her. She's super busy, she's doing a million things, and yet she took the time to take care of this course and workshop. I'd like to give a small word to Dr. Rasha Gamal. Thank you, Mandy. Good morning, everyone. I'm Dr. Rasha Gamal, the Director of Cairo University Specialized Pediatric Hospital. Actually, we have been waiting for this visit for years and years. So let me take a minute to honor Dr. Samia Sabri and the distinguished team. Thank you so much for taking the time and the effort to come here. Looking for collaboration in the service of our patients. One last word. Let us take a moment to remember Professor Dr. Samir Hassaoui, our distinguished professor of pulmonology. I'm quite sure she is happy now watching this visit happen. Thank you so much once more, and enjoy your visit in the hospital and in Egypt in general. Thank you. Dr. Samia, thank you very much, Dr. Rasha, and all the team from the hospital management, And I would like also to remember Dr. Samiha, who is the main reason why I got to know Dr. Samiha in the very beginning. She introduced her to our hospital the first time she came. So, Dr. Rahman will introduce our next speaker. Let's move to our next speaker. Our next speaker is Dr. Amy. Dr. Amy will talk about screening and treatment, clinical practice guidelines.
Thank you so much for having me here today. Happy to be back. This is my third presentation, and I'm very glad to be here. I'm going to talk today about two of our clinical practice guidelines. I know Sammy has mentioned those at the top, and I'm going to talk through two of them with you today. The first one is our cystic fibrosis related diabetes screening and treatment clinical practice guideline. The goal of this practice guideline is really to focus on the diagnosis and management of CFRD. So the diagnosis is associated with an accelerated decline in lung function, which is part of why it's so important to make the diagnosis as soon as you can and start treatment. We see a decline in lung function, a decline in nutritional status, and this leads to the microvascular complications and increased mortality in patients with cystic fibrosis. So the protocol contains our up-to-date guidelines for managing the disease and also impaired glucose tolerance, including guidelines for screening, diagnosis, and monitoring. The purpose of the protocol is really to optimize our lung function, growth, and BMI, and then decrease, hopefully, the incidence of diabetes. Certainly, Trikafta has been also helpful in helping with management of that part of the disease as well. And then we want to align our services between our endocrine partners and our pulmonologists. So the indications for this clinical practice guideline: pediatric pulmonology clinic. Our clinic implemented screening recommendations for CFRD based on screening procedures, and to initiate the protocol for pediatric endocrinology to occur when patients with CF are referred for elevated OGTT, oral glucose tolerance testing. So a 2-hour OGTT of over 200 is what's considered positive for us, or a hemoglobin A1C that's 6.5% or higher. And we do annual screening for patients 10 years and older with an OGTT, but we do hemoglobin A1Cs from birth onward every year. So our screening procedure, we screen for impaired glucose tolerance and CFRD using a random glucose and a hemoglobin A1C annually, as I said, for all of our patients. The screening is done through our clinic. We order those labs. We don't send them to endocrine unless we diagnose and have a positive screen. And then we do an OGTT for patients starting at 10 years of age, younger if they're showing signs or symptoms that might be concerning for diabetes. Then we would get one in younger patients as well. And then we use, again, a 2-hour OGTT with 1.75 grams per kilo of glucose to a maximum of 75 grams of glucose. We do a baseline fasting glucose and then the 2-hour testing after at least an 8-hour overnight fast. Okay. There, got it. Okay, so during an acute exacerbation, that is another time when we can see glucose levels go high. So when people have, I'm very right-handed. Okay, so when people are sick, glucoses can be high, and so in the hospital, we will often monitor glucose levels. We don't often do our 2-hour OGTT in the hospital. But we do monitor glucose levels at baseline and at 2 hours after feeding, sometimes also before meals. Initially when they come in, to make sure that we're not seeing signs of diabetes during that acute phase that needs management. If we do see those signs, then we will consult our endocrine partners to help us determine if we should start some insulin. Just even when they're in the hospital, that will be stopped as they start improving, because not always do they have long-term issues at the beginning. And then we have some pregnancy guidelines as well, which our adult colleagues manage more than we do. But we do screening through standard, our standard labs for our patients when they become pregnant. So screening procedures again, we place the orders. We don't ask our endocrine colleagues to place those orders initially. We monitor the patients who have impaired glucose tolerance and only refer to endocrine once they meet the diagnosis of actual CFRD. And these are the categories of abnormal glucose tolerance in our CF population. Okay, so normal glucose is considered less than 100 at fasting and less than 140 2 hours after an OGTT. We have indeterminate glycemia when your fasting is less than 120, but your 2 hour might be higher. And then we have impaired glucose tolerance when your 2 hour becomes between 140 and 199, and your fasting is less than 100. And then we have our CF without fasting hyperglycemia, so your OGTT is greater than 200 at 2 hours, but your fasting is still normal. And then we have CFRD with fasting hyperglycemia when both of these are high. Now, if you just have a fasting over 126, you don't technically need the 2 hour to already say that you meet criteria. I would say that a minority of our patients meet that criteria. Most of our patients begin with a 2 hour that's high, but a normal fasting glucose. So the diagnosis is made, again, if two of the following are found on separate days. So a 2 hour OGTT greater than 200, a fasting glucose greater than 126, again, and or postprandial that's greater than 200. And also we consider a hemoglobin A1C greater than 6.5% to be consistent with cystic fibrosis related diabetes. And then these do need to be repeated. Oftentimes we will make the referral to our endocrinologists when we have them the first time, and they will repeat these before they initiate any treatment. If they repeat them and they're not still in that abnormal range, then they will monitor and have them check glucoses at home. So again, we can make the diagnosis during acute illness as well, but it doesn't always continue to be an issue once that acute illness is treated. Sometimes we see it only during acute illness early on, and then later over time we may develop a more consistent picture of CFRD that requires treatment long term. And the diagnosis can be made with patients on continuous enteral feeds when the mid or post-feeding glucose levels exceed 200 on 2 different days. So recommendations, our dietitian counsels patients with any degree of abnormal glucose tolerance on decreasing the intake of excess sugar, such as sugary beverages, cookies, candies, things like that. We obviously have to walk a fine line to keep their nutrition good, so we give them healthier options for meeting their nutritional goals than a lot of extra sugar. The goal for pediatric endocrinology is to prescribe as much insulin as can be safely tolerated to eliminate the catabolic effects of CFRD and reduce the risks of complications associated with diabetes. But we have to make sure that they're continuing, again, to receive all of the nutritional needs that they have, which is certainly higher than the average type 1 diabetic or other diabetics where it's easier to cut carbs and do those kinds of things. So in our CF population, I think it's a little more of a challenge to manage the diet. Patients will not be asked to limit carbs to avoid insulin, but to use carb counting and use enough insulin to be able to continue to receive that nutrition. And then endocrinology will take over once we have those positive tests. They'll determine when patients are going to check their glucoses. Usually once they've met those diagnostic criteria, they check at breakfast, 2 hours after lunch, 2 hours after lunch, dinner and bedtime. If they're on basal insulin, they get a check overnight, midnight or 3 a.m. as well. Once the initial doses are determined, again, then they're just checking breakfast, lunch, dinner, and then the bedtime checks. If they do not eat at those times, then blood sugars need to be checked and a correction given, right? And then if they're on continuous feeds, you need to check before starting the feed, 4 hours into the feed, end of feed. It does make it a little more challenging when we have people on continuous feeds, of course. Let's see, and then continuous glucose monitoring is being used more and more readily for us. I don't know if that's as readily available here or not, but that is one way that we are having a little bit more ease in monitoring levels and understanding what the real insulin needs will be. Dosing-wise, patients tend to be more insulin sensitive when they're healthy and at their baseline as opposed to when they are acutely ill. So they require less basal insulin when they're healthy and often more when they're sick. The recommended total doses, are usually 0.5 to 0.8 units per kilo per day, more bolus than basal insulin. In early CFRD, bolus insulin may be what they need only, and they don't need basal insulin. But once fasting glucoses start to be high, that's really where basal insulin comes in as well. During illnesses, oftentimes we have to increase both their basal and bolus insulin dosing, and then as they improve, we go down. Same thing if they need an oral steroid course or an IV steroid course. You often have to do a lot of adjusting for those. Again, that's one of the more complicating factors for some of our patients. So we do recommend that our patients be seen by pediatric endocrinology within 2 to 4 weeks of getting those initial positive lab tests. And then they should be followed quarterly by visits to endocrinology. And we are fortunate enough now to have an endocrinologist who is actually coming and doing some joint clinics with us, which is really convenient for our patients to be able to get their visits done together. So that's been fantastic. We're really happy to have her, and that has just started up this year. Patients should be given ongoing self-management education, and really, just like CF education is so important, diabetes education is so important in terms of self-management and long-term control. So education is really, really a big part of this, and those on insulin should be checking their glucoses. Our goal is to keep our hemoglobin A1C less than 7%, ideally less than 5.5%, and that is checked quarterly once they have the diagnosis. And then blood glucose goals are the same as for individuals with type 1 diabetes, as recommended by the American Diabetes Association for us. And then insulin pumps, just like continuous glucose monitors, are becoming more and more the norm for us. It really does help people to be able to manage their diabetes better. So those who qualify, that is what we're doing. And then just to chat briefly about impaired glucose tolerance, pediatric pulmonology again monitors for this. If we see this, we only really refer to pediatric endocrine when they're really not growing well. So if their BMI is less than the 30th percentile or less than 20 kilograms per meter squared for those who are 20 and older. If they're having a persistent decline in their FEV1 or more frequent exacerbations than pre-diagnosis, that's another time when we'll refer even though they don't meet the full criteria for CFRD. And again, if they're having typical diabetes type symptoms as well. So monitoring for CFRD, again, if you're not on insulin therapy and we have made the diagnosis, then we recommend checking blood glucose levels 3 times a day, fasting before meal and after a meal 3 times a week. And then when you're on insulin, the self-monitoring goes along with that, and you're checking at least 4 times a day or using continuous glucose monitoring. Hemoglobin A1Cs, once you have a diagnosis, are checked every 3 months. Again, the target less than 7%, ideally less than 5.5%. And continuous glucose monitoring, again, is becoming more readily available for us, so it's becoming a big part of patient management. Complication screening, blood pressure measurement is done at all routine visits. Annual screening for other microvascular complications generally begins 5 years after the diagnosis of CFRD, so eye exams for retinopathy, urine albumin to creatinine ratio, annual foot exams, and lipid profiles for these patients who have risk factors for hyperlipidemia, especially those, as we have more and more tricatheter use, we have more and more patients actually falling over into the obese category, where we used to struggle much more with failure to thrive. So we are seeing more complications related to that. And then pulmonary function testing we do every time that they come to a clinic visit once they're 5 and up. Monitoring on insulin, they should see our endocrinologist every 3 months. They check the glucoses as we've already talked about here. And parents are told to update endocrinology if they start seeing fasting blood glucoses hitting over 120 on more than half of their checks, or other glucose monitor checks over 180 more than half of the time, or if they're having low glucose levels. And certainly if they're having any moderate to severe low glucose levels, we should let endocrine know right away. If you're not on insulin, then they see the endocrinologist every 6 months. And certainly again, if they're having other signs of issues, decline in PFTs, more typical diabetes symptoms, and then before their visits, they do a little bit more monitoring. Okay. That is all I have on CFRD, and if there are questions on that, I can take those when I can move on. Thank you.
Thank you, Dr. Damon. My question is it only related to endocrinology problems, like just the diabetes, or are there other metabolic problems that you may face?
The biggest one is certainly diabetes. I mean, obviously there's obesity issues and other things in those areas that we see as well. Other metabolic syndromes, I don't know that there's specific other metabolic syndromes. So anything off the top of your head that you think is metabolic syndrome-wise?
We just face a lot of electrolyte disturbances and further life problems.
I think we can see those, we have seen those certainly in our infants. But beyond that, we don't see them very often for us. Of course, with newborn screening, we're making the diagnosis very early, which is very helpful for that.
Thank you. Any other questions? Okay, so I think we can make a short break for about 15 or 20 minutes. We have some refreshments in the back, and then we're going to come back with Dr. Sharon on the next talk. Do we have any other talks?
Amy's got one. Don't you have one more? Well, we have
So and then some refreshments, coffee break. We have